Okay, combination therapy once and for all. Interesting title. I don't think this is going to go away once and for all. I think we'll probably be having this debate over the next few years. But, I'm really quite confident in the position that I've been allocated here, and I'll take you through this. Just briefly, though, this is the real education part. How to win a debate. Well, the first thing you should do is always suck up to your audience. This is the best looking crowd I've ever seen at a medical meeting. Second thing is denigrate your opponent. And as much as I'd like to, I saw Steve's slides and he didn't use fake news like network meta-analysis to support his point, and so I'm not going to do that. And thirdly is distort the facts to make your case, and I don't have to do that, as you'll see. So monoclonal antibody therapy, these are the pivotal trials, which weren't combo therapy trials, and you can see how miserably we do with the TNF blockers. Only 20% of patients getting into remission if you use the benchmark of steroid-free remission. So we've got a long way to go, and I'd submit that combination therapy is the only way we're going to get there. The theoretical advantages, you're all familiar with this. Combined therapy, prevention of immunogenicity, really allows you to keep drugs in play for a long period of time, increase drug concentrations, and targeting multiple mechanisms, which as our oncology friends and HIV, Hep C, this is the way forward with complex disease processes. One drug doesn't do it. The disadvantages, we'll talk about toxicity and increased cost. And you can't pick up the New England Journal of Medicine. Every week there's a study like this in myeloma, showing the benefits of combination therapy in cancer. It's clearly the way forward. And then Hep C. Our hepatologists, I don't like talking to hepatologists, but you have to sometimes, and they've got huge advantages over us because they've embraced the concept of combination therapy. And the whole Gilead has led the way forward in that. Good chemistry, multiple targets. So why can't we understand that? We know that the concept of step care based on incremental monotherapy is dead in 2017. It's broken, and you're going to hear that in the debate later on, that I can't believe anyone is advocating one-size-fits-all step care based on monotherapy. It's yesterday's diagram, and I think I got this from Steve, actually, years ago. And unfortunately, that's not the way we should be treating patients in 2017. And our good old school monotherapy, azathioprine, well, it's just about to exit stage fright, okay? It's yesterday's drug. And we started to understand this back in the study by Jacques Cohn that showed no benefit, it seemed, from extensive use of azathioprine monotherapy. And then the Europeans did two pivotal studies, Aztec and the Jetade study, which showed that azathioprine introduced early had no benefit. So monotherapy with conventional immunosuppression, what we all grew up with, is not the way to deal with this disease. And we started to understand, this is the first study ever done of an algorithm of treatment in Crohn's disease, the top-down study, and what it showed that early introduction of combined therapy was more effective than step care. And this was a tortoise and hare type study, and at the end of 2 years you could say, well, there's no different, Brian, so it doesn't make any difference. But actually, when you look at mucosal healing, hospitalization, and surgery, what you do up front matters. So it's like the surgeons, trauma surgeons, in the golden hour. You have an opportunity to actually intervene successfully by delivering highly effective therapy. And I hate it when people use the term aggressive therapy. This isn't aggressive therapy. You're being aggressive to your patients by not introducing effective therapy. So acts of omission are just as bad as acts of commission. So we should be thinking about highly effective therapy. And then really Sonic changed the world. So how can you argue this is relatively early disease showing clear superiority for introduction of combination therapy versus monotherapy with azathioprine and monotherapy with infliximab? Hard to argue with that. Notice there's no placebo. What would azathioprine look like against placebo in this situation? And then, as alluded to earlier, I think we've sealed the deal with the REACT study. So this is the largest study ever conducted in Crohn's disease. It was a cluster randomization trial. We randomized 30 practices in Belgium and Canada, community gastroenterology practice. And the reason we did this was because when I was speaking at various places in the community, people would come up to me and say, Brian, you can talk about combination therapy, but I know if I do this, I'm going to kill someone. Whereas in a tertiary care center, you've got all those resources, you can do this, but I can't. So we did this study to show, in fact, that that wasn't correct. And what we showed was that if you were assigned to the early intervention with the combined therapy group, that complications, surgery, hospitalizations were lower, significantly lower. And this is 2,000 patients, a 7% difference over a period of 2 years. And to me, that's clinically important. That's what we care about. It's not disease activity as measured by the Harvey-Bradshaw score. And to answer the question, and I don't think I have the slide that I thought I had, REACT was big enough that we could actually look at mortality as an endpoint, the thing everyone worries about. And guess what? The mortality was higher in the conventional therapy group, 1.1% versus 0.9%. So you can do this safely in the community. So switching gears, what about other drugs beyond infliximab? Well, adalimumab, we have this Japanese study, and it has to be difficult to interpret this study. I mean, these rates of mucosal healing are really, really high, extremely high. The study wasn't blinded with regard to central reading, but again, it's consistent with the notion that there is a beneficial effect. So I want to come back now. So I've made the case generally that combination therapy is more effective than monotherapy. Why is that? Well, the advantages here, prevention of immunogenicity, increased drug concentrations, and hitting multiple targets. The concept of sensitization, as gastroenterologists, we were really stupid 20 years ago because the notion of sensitization to foreign proteins had been worked out by these two gentlemen in the 1940s when they really set the stage for organ transplant. And they recognized that there are multiple determinants of sensitization and that you really can't expect to give a foreign protein, no matter what cell line it grew up in, and not get sensitization. And it took us many years to sort this out, and this study was really a pivotal study coming out of Leuven, demonstrating that, yes, in fact, you do sensitize to infliximab, and that had clinical consequences. And sure enough, it took some years, though, a decade later, to show that that was really successful for the quotation marks fully human antibody. Because it really doesn't matter whose cell line the drug was developed, well, whose antibody it is. It's not your antibody. Your immune system has evolved over millions of years to do one thing, to detect self from non-self, and it's very good at it. So this is just showing that sensitization is an issue with adalimumab. And then we did, I think one of the studies I'm really quite proud of, is this was a multi-center international collaboration which asked the question, well, if you have therapeutic drug levels, do antibodies matter? And the answer in a multivariable analysis was yes, they do. They're independent. So this is telling us that, it's not all about the trough level, because, if you've got a therapeutic trough level, we still see the presence of anti-drug antibodies being a significant factor in whether you're in remission or not. So antibodies matter. Combination therapy prevents immunogenicity. And this is, again, coming back to SONIC, you can see that if you're on monotherapy, the rates of sensitization, 15% versus 1%. So quite striking difference. And then secondly, increased drug concentrations. Well, SONIC again. So this study, this figure is really important concept. So combination therapy is the poor man's dose intensification. So you look at trough levels here, they're twice as high in the group receiving combination therapy as monotherapy, 3.5 versus 1.6. Well, those of you who use TDM will recognize that 3 plus that's the median value. So it means that the 1.6, over half of your patients don't have a therapeutic drug level if you're on monotherapy. It's a huge difference. Pretty striking. Other approaches. Well, ustekinumab, we're going to hear later on about it, and the IL-23 story. You've got a new drug now. It can be given as a monotherapy. The sensitization rates are very low. It's probably the real outlier of all the biologic drugs we have. It's effective, and you're going to be seeing more of that. And I'll take it that combination therapy with ustekinumab still needs to be proven. The sensitization issue isn't on the table, but they could still have additivity for the reasons that we talked about. Just briefly want to comment about UC. Step care is alive and well in UC because 5-ASA is such a great platform drug. So we still have that issue. But guidelines now are saying combo therapy with either TNF blocker or vedolizumab as first-line therapy. Azathioprine monotherapy is off the table now. And we do have the USC success story, which is mini-me for Sonic, indicating that combo therapy in UC is more effective than monotherapy. And there looks at mucosal healing data from that study. And the guidelines now recommend combo therapy. Vedolizumab, combo therapy with Vedo. Well, yeah, it sensitizes to the same degree as the other drugs. So if you want to protect your drug, you should think about it. Let's come to safety, which is the key argument that I hope Steve will make. And I think we've got very good data to refute any of those arguments. This is the #1 problem with TNF blockers, lobar pneumonia. And in TREAT, we looked at what the risk factors for developing such a serious infection were, and we identified them on. It took about 6 years of follow-up in TREAT to identify in multivariable analysis that infliximab was an independent risk factor for serious infection. It took 6 months for steroids, narcotics pretty much too. Disease activity is another independent risk factor. Note you don't see combination therapy on this graph for a reason. There was no association with combination therapy. The risk was the same as for monotherapy. And the largest controlled trial shows the same thing. There is no increased risk. Well, how could that be? I'm a smart physician. I went to medical school, right? 1 + 1 has to equal 2, right? If I take infliximab, which is a risk, and God knows that methotrexate and AZA have to have a risk, 1 + 1 has to equal 2. So why not? Well, what you're missing is the key part of the equation. 1 + 1 does equal 2, but there's a -1 in there, because if you get more patients into remission with an effective therapy, then the risk for a population goes down. And that's why you don't see an increased risk. And then coming back, this is a slide that I said was missing. It's not missing. There are the data. REACT, 2,000 patients. There is no increased risk of either serious infection or mortality in REACT. And the reason for that is that equation, 1 + 1 - 1 = 1. What about cancer? Azathioprine is associated with cancer. And the SESAM study shows, though, that's in over 60-year-olds. So I don't want to provoke another fight with Miguel, God forbid. But I'll give him that, taking azathioprine off in 60-year-olds. I don't have a problem with that. I'll give you that one. And then lymphoma, probably the biggest issue. Again, that is a disease of the elderly. Hepatic splenic T-cell lymphoma, it's vanishingly rare. And I hope that wouldn't drive any of your logical decision-making, that entity. So I'm going to summarize here. I've made the case that combination therapy is more effective. I can't believe there's any debate about that. In the absence of high-quality data, this conclusion, which is based on infliximab, can be generalized to other agents. So if we're saying, well, it doesn't apply to whatever, you have to show me, and there's no data. Highest quality data do not support an increased risk of serious infection. We've got a very large clinical trial. We've got the REACT study. This sort of voodoo that somehow you're going to kill everyone with combination therapy, I really don't think is based in reality. And then co-administration of immunosuppressive is not necessary for USTA. I think I want you to understand that. As far as immunogenicity, we don't know whether combo with USTA is likely to be more effective than monotherapy. That study needs to be done. As safer agents become available for inclusion regimens, combination therapy is likely to become more prevalent. So think about it. Vedo is a platform agent for combo therapy. Why not? And then finally, I'll just say this, I absolutely believe this, that the only way we're going to get the deal done in this disease, to have 80%, 90% remission rates, steroid-free remission rates, is through combination therapy. And we need to pay more attention to what's going on in other fields. And that's been the way forward with things like HIV, viral disease, cancer. So I'll stop there and thank you.